All right. So, good evening and welcome to the fourth edition of the IAAS webinar. And we have two distinguished moderators for today's session. I will introduce them to you. One is Professor Zhang from China. He is the director of the CASA, that is the Chinese Association for Ambulatory Surgery. And he has been the member of the management committee, the EXCO, and the management body of the IAAS for almost a decade. A pioneer in developing ambulatory surgery in China, and the Republic of China has hosted the IAAS Congress, which we all attended. It was one of the wonderful events. We also have Nanda Kishore Manoharan, who's a general surgeon from the city of Chennai, and he is the general secretary of the Indian Association of Day Surgery, and he is currently also the member of the management committee. I hand over to you both. Nanda.
Thank you, Naresh, and welcome everybody to this webinar. I think our speaker, Kirsti, Siik, is from Finland, and she'll be talking on joint replacement as ambulatory surgery in Finland. Now, Kirsti, holds a master's degree in science and has a professional background as a registered nurse researcher in patient education and nurse in ambulatory surgery. And she is currently affiliated to Coxa Hospital for joint replacement. And she has served in various positions. Since 2017, she has served as a chairman of the Finnish Association of Ambulatory Surgery and a member of the IAAS General Assembly. Her career includes 15 years as a nurse manager and 13 years as an assistant nurse manager. Her major achievements include redesigning the ambulatory surgery process, contributing to construction project for a new operating room and ambulatory surgery department, and participating in the merger of 4 operating departments. Over to Kirsti.
Thank you. So greetings from Finland, and thank you for the, no, sorry, my computer is working himself. So thank you for the opportunity to talk about how joint replacement is done as ambulatory surgery in Finland. I try to provide a clear, practical overview. Overview of ambulatory joint replacement. By the end of this presentation, you will know what ambulatory joint replacement means, understand how important patient selection criteria is, review the perioperative pathway, discuss practical benefits and challenges. For this presentation, I have tried to gather information on how joint replacement surgery is performed as ambulatory surgery in Finland. I will talk about some differences in the end of the presentation, so my presentation might last a few minutes longer. In 2024, approximately 13,000 primary hip replacements, 18,500 primary knee replacements, and 1,300 primary shoulder replacements were performed in Finland. The number of primary surgeries increased by about 20% from the previous year. However, the number of ambulatory joint replacement surgeries is not yet known. The Finnish Institute for Health and Welfare has indicated that these figures will be included in the 2025 statistics. More than 8,000 surgeries, or about 1/4 of the total, were performed at Coxa Hospital for joint replacement. At Coxa, approximately 47 of these surgeries are ambulatory. Other hospitals perform significantly fewer surgeries. Ambulatory joint replacement refers to joint arthroplasty procedures where patients are discharged home on the same day as surgery without an overnight hospital stay. This approach can be used for hip, knee, and shoulder replacements. However, not all joint replacements are suitable. Selection depends on procedure type and complexity. It is only appropriate for carefully selected patients who meet specific criteria for safety and recovery. Patient selection is a critical factor for safety and success. Patients are discharged within hours after surgery, provided they meet recovery criteria. Ambulatory joint replacement enhances both patient experience and healthcare efficiency. Not all patients are suitable for same-day discharge. Selection depends on the procedure, its complexity, and the patient's health status. Key selection criteria include patient motivation and understanding are essential. Candidates must understand the procedure and follow post-operative instructions. Adequate social support is essential. A reliable caregiver should be available at home until the following day. Low surgical risk is required. Patients must be medically optimized and underlying conditions well controlled. These criteria support safety, efficiency, and good outcomes in ambulatory joint replacement. Careful patient selection is key to safe recovery at home. Although these guidelines provide useful framework, final decisions are made individually. In all hospitals, absolute criteria include patient motivation, the ability to follow post-operative instructions, a single joint procedure, and continuous caregiver support until the following day. Comprehensive support and careful follow-up are essential for successful recovery. Preoperative education and thorough preparation are fundamental to reducing patient anxiety and enabling early discharge after joint replacement surgery. By ensuring patients understand the procedure, its risks, and recovery expectations, we empower them to actively participate in their own care. This support helps alleviate fears, foster realistic expectations, and builds the confidence necessary for a smooth transition home. Providing detailed information about the surgical process, pain management, mobility expectations, and post-operative care helps patients feel prepared and capable. Engaging patients in preoperative physical therapy strengthens muscles, improves joint function, and prepares them for post-operative mobility. This proactive approach can speed up recovery and reduce complications. Addressing underlying health issues such as diabetes, hypertension, sleep apnea, or anemia prior to surgery ensures patients are in optimal condition. This reduces surgical risk and supports safe, efficient recovery. Early discussions about post-operative needs, home support, and criteria for discharge ensure patients and caregivers are well prepared. This proactive planning minimizes delays and facilitates safe transitions home. Modern anesthesia and pain management techniques are essentials for successful ambulatory joint replacement. Spinal anesthesia is frequently chosen for its effective pain control during and after surgery, few systemic side effects, and it allows patient alertness. If desired, the patient can receive light sedation with propofol during the operation. Employing a combination of medication and techniques addresses pain through multiple pathways. This approach maximizes pain relief and minimizes reliance on any single medication. By integrating regional anesthesia and multimodal pain management, opioid use can be significantly reduced, lowering the risk of side effects such as nausea, constipation, and drowsiness. During the operation, the focus should be on efficiency, safety, and consistency. Minimally invasive techniques reduce tissue damage, help decrease pain, and support faster recovery, which is important for same-day discharge. Strategies to minimize blood loss, such as careful surgical techniques or medications, help reduce the need of transfusions and speed up recovery. Using established evidence-based steps ensures high-quality care and reduces variation, leading to safer and more predictable outcomes. Effective postoperative care is crucial for a smooth recovery and same-day discharge. Encourage patients to get out of bed and start moving as soon as possible after surgery. This helps prevent complications like blood clots, improves muscle strength, and promotes confidence in self-care. Although the first days only walk in, which is necessary. Allowing patients to eat and drink soon after surgery supports faster recovery and reduces the risk of dehydration or nutritional deficiencies. Proactively managing pain and nausea with effective medications and strategies ensures patient comfort, prevents complications, and makes home recovery safer and more manageable. Patients are only discharged when they meet specific medical criteria, not simply after a set amount of time has passed. This approach ensures patient safety and successful recovery. Everyone moves at their own pace, and readiness for discharge is carefully assessed. Vital signs must be stable. They must be able to pass urine in hospital before going home. There must not be excessive bleeding. If the dressing must be changed more than 3 times, the patient must remain in the hospital. In that case, there are differences between hospitals. Pain should be managed effectively with oral medications, so the patient is comfortable enough to go home and continue recovery without the need for intravenous pain relief. The patient must be able to move independently, walking, getting in and out of bed, and performing basic self-care so they can safely manage at home. There must be a safe plan for home care, including support from family or friends, at least until the following day, and clear instructions for managing recovery and recognizing any warning signs. High-quality patient care and recovery rely on a multidisciplinary team. By working together across surgery, anesthesia, rehabilitation, safety, and comfort, these professionals address the patient's full needs, improve outcomes, and reduce complications, and support a safe transition home. Ambulatory joint replacement enhances both patient experience and healthcare efficiency. Patients can return home faster, which minimizes disruption to their daily routines and lowers the risk of hospital-acquired infections. Early discharge and efficient care processes decrease the likelihood of postoperative complications, benefiting both patients and providers. Patients appreciate being able to recover in familiar surroundings, leading to greater comfort and satisfaction with their care. This approach streamlines hospital operations and allows resources to be used more effectively. Although ambulatory joint replacement offers clear benefits, it also involves challenges and risks. Effective follow-up and patient support are key to success. Patients may feel uneasy about going home soon after surgery, especially if they are unsure what to expect. Clear communication, education, and reassurance can ease these concerns. Pain management at home can be difficult. Patients need clear instructions, access to medication, and provider support to stay comfortable and avoid complications. Some patients may need to return to the hospital due to complications or slow recovery. Careful selection, clear discharge criteria, and strong follow-up help reduce this risk. Another challenge may be the attitudes or skepticism of healthcare staff towards day surgery and patients' ability to cope, until trust is built as it becomes clear that patients are satisfied and managed well. Empowering nurses is directly linked to improved patient outcomes, such as satisfaction, faster recovery, and well-being. In summary, these challenges require coordinated teamwork, clear communication, and reliable post-discharge support. With proactive risk management and strong follow-up, ambulatory joint replacement can remain a safe and effective option. The intraoperative phase is largely similar in all hospitals. Differences mainly occur before and after surgery. Larger hospitals are generally more liberal than smaller ones. And I have a few examples. Patient selection varies, especially in private hospitals where criteria is stricter and patients are generally healthier. Key factors include comorbidities, obesity, mobility, and distance and accessibility at home. Acceptance of ASA3 patients depends on the unit and anesthesiologists. Home preparation differs. Instructions may include normal washing, chlorhexidine wash, mupirocin nasal ointment before surgery, or preoperative drinks. Physiotherapist involvement varies. Guidance on crutch, walking exercises, and assistive devices may be given before surgery or only before discharge. Medication practices vary. Some hospitals prescribe medicines in advance, while others arrange ward pharmacy delivery before discharge. Opioid descriptions vary in type and amount, including immediate and prolonged release opioids. Thrombosis prophylaxis is based on patient-specific judgment. If needed, LMVH is usually used with duration decided individually. Follow-up varies from no routine contact to next day or 7-day checks by phone or app. Coxa Hospital for joint replacement also offers 24/7 customer service. Physician involvement also vary. Private sector physicians may contact patients after surgery, while elsewhere contact may be limited to the postoperative X-ray visit. Ambulatory joint replacement proves to be a highly effective approach by focusing on efficient care, early discharge, and comprehensive patient support, both clinical outcomes and patient satisfaction are optimized. Ambulatory joint replacement is safe and effective when patients are carefully selected and standardized clinical pathways are followed. Remember, first better, then faster. Prioritize quality and safety before striving for speed. Ultimately, with collaboration, attention to patient needs, and a commitment to continual improvement, ambulatory joint replacement can deliver safe recoveries, lower complication rates, and greater satisfaction in all involved. This is an overview from the situation on July 28th from my own workplace. If you want to just watch. I did so same kind in Dubrovnik. So there are 27.8% of all primary protheses are day cases. So thank you. This is me with my knee prosthesis in a picture. Exactly 2 years ago. Thank you.
Wonderful. Wonderful. Nanda, unmute yourself, Nanda.
Sorry. Thank you, Kirsti, for the wonderful presentation. And I think we have the questions at the last. So
Sure.
I think Professor Zhang will introduce Joana.
Professor, you are also muted.
接下来呢，我们请来自西班牙的Joana Correia为我们介绍减重手术的日间手术模式的应用。
So our next speaker is Joana Correia from Portugal, and she's going to make a presentation titled Bariatric Surgery in Ambulatory Setting.
Hi, good afternoon to everyone. I'm only trying to share with you the presentation. Because
yeah, go ahead. This is fine.
Yes. So sorry for this delay.
No problem.
So my name is Joana, and I'm the head of the abdominal wall unit at Pedro Spano Hospital in Portugal. And we are trying to talk about the bariatric surgery in an ambulatory setting. So I don't have any kind of disclosure for this presentation, but my major disclosure is that I am not a bariatric surgeon and I do not belong to a bariatric team, but as an abdominal wall surgeon and with the planet, with the problem of obesity, we have lots of patients with hernias and obesity, so we need to deal with these two problems. So one of my best friends is my bariatric surgeon and the bariatric team, Professor Gil Faria. So I'm trying in this presentation to review since when in our hospital we are doing bariatric surgery in one-day surgery, what kind of surgeries are we doing, what are the inclusion criteria, and what are the clinical outcomes. And we started between 2020 and 2021 because of the COVID pandemic and because we have lots of patients waiting for this kind of surgery. In that year, we start with outpatient sleeve gastrectomy, and in 2023, we start with gastric bypass surgery. Because of that, and because it's a more complex surgery and a more complex patients, we define several inclusion criteria. Not only the usually inclusion criteria of ambulatory surgery, the durations of the surgery, the blood loss, the anesthetic risk, the pain control, the available transportation to home, the patient living less than 1 hour away from our hospital with adequate living conditions and phone accessibility, but also some patient eligibility associated with obesity and associated with some kind of anesthetic problems. So all these patients were previously evaluated in a multidisciplinary meeting. All these patients don't have any kind of history of supramesocollic surgery in order to avoid a more complicated surgery. They don't perform other additional procedures in these kind of patients. These patients are not anti-aggregated or anticoagulated patients, and all the comorbidities are adjusted to this concept of one-day surgery. But also our anesthetic team evaluate these patients, our nurse team and our nutritionists, in order to allow a very good patient education and a more secure post-discharge home support. And in the surgery, during the surgery, you have always a very experienced team in bariatric surgery. We have the same anesthetists using an opioid sparing protocols, and all the patients have very smoothly surgeries. If any kind of small problem, of small technique problems during the surgery, these kind of patients don't go home and are admitted in order to have more safety. All these patients after the surgery starts clear liquids and a very early deambulations, and they are only discharged if they have their pain control, they tolerate oral diet, and the patient was comfortable with this discharge. For home, they gave them analgesics, antiemetics, thromboprophylaxis, and the multivitamin complex. All of these patients have pulse oximeters to evaluate vital signs at homes. All of them have the direct telephone number of the unit. They gave them informative leaflets, and all of the patients are contacted by phone in the first day post-op and are communicated with the surgeon in an appointment at the hospital in the second day after the surgery and in the 30 day after the surgery. So why all of this control? Because we have afraid of the two major complications of these patients. In the hospital, we can have hemorrhagic complications, but all of the scoring systems that allow us to discharge patients in an ambulatory setting evaluate the risk of blood, of an hemorrhage. So when these patients are discharged, all of them don't present any kind of alterations in vital signs that we think they have any kind of hemorrhagic problems. And the second complications are the anastomotic leaks. But in the scientific reviews, we can understand that when the patients have an anastomotic leak inside the hospital or at home, they have very early alterations in vital signs like the heart rate, the respiratory rate, and the saturation. And it's because of that all of these patients have the pulse oximeter at home in order to verify these vital signs in these first 48 hours in order to catch any kind of alterations that can make some suspicion of an anastomotic leak, and the patients come back to the hospital. So what kind of clinical outcomes are we having right now? Here we are not comparing different techniques with different bariatric results. We are here talking about measuring safety and measuring if doing this kind of procedure in ambulatory setting, it's safe or not. And for these first years, we have more than 150 patients for sleeve gastrectomy with a median age of more than 40 years, 90% of them females, and with a BMI of more than 40, all of them with several comorbidity optimized for the surgery. And gastric bypass surgery, we have more than 40 patients with a median age around 40, and still here with the predominance of females, and a BMI a little bit higher than the sleeve as usually. And for sleeve gastrectomy, we have a duration of the surgery of 70 minutes. In 40% of the cases, we have to do an overnight stay, and less than 4% were admitted. I must say that in Portugal, we have the ambulatory surgery is till 23 and 59 minutes. So most of these patients get their surgeries during the afternoon, and they make the overnight in the ambulatory setting and are discharged in the next day. And all these inpatient admissions in sleeve and in gastric bypass were decided during surgery. So it was because of some kind of small problem, technical problem during the surgery that led the surgeons to decide it's better to admit these patients and follow up inside the hospital than to give them discharge home. None of these patients were admitted after the discharge because of the complication and came back. For gastric bypass, we have a surgery duration of more than 100 minutes, an overnight stay a little bit bigger, more than 60%, and we understand that because of the kind of surgery and sometimes because of the hour of the surgery, and inpatient admissions a little bit higher, and we understand that it's a more complex surgery, so some technical issues can happen. And in ambulatory setting, we have even low threshold to admit the patient. But about complications, we must admit that we have only one postoperative complication in sleeve gastrectomy with one organ space infection and two with gastric bypass, also with organ space infection, and all of them were detected at 48 hours in the appointment with the surgeon, and the patient were admitted and the problem was solved. So for the question if it's safe performing bariatric surgery in an ambulatory setting, in our own experience, it seems to be feasible, safe and successful, but I must admit that our ambulatory setting includes overnight. And I think as final thoughts, that although it's safely, probably it is safe because we have a very careful patient selections, not only in the surgical characteristics of the patients, but also because of the selection of anesthetic characteristics. And we have this system of a very early detection of complications that gives this safeness networking for the patients and for all the teams. And it's not only the expertise of the surgeons, but it's also the expertise of the anesthetists, the nurses, and all the multidisciplinary team that have much experience with these patients and much experience with this kind of one-day surgery. So it's not only one thing. I think it's a very thoughtful chain of things that allow us the safety for these patients. So thank you, and I invite you all to read this new book of International Manual of Ambulatory Surgery, A Global Perspective. Thank you.
里边呢会有介绍从
非常感谢 Joana 给我们做了精彩的演讲，这是我第二次听她介绍减重手术在日间手术当中的这些做法和经验了。
Thank you, Joana, for this wonderful presentation. This is already the second time for me to learn about your practices in bariatric surgery in ambulatory setting. I'm very impressed.
在克罗地亚的日间手术国际大会上，他做介绍的时候就已经引起了会上参会人员的这个反响，大家非常关注他所讲的这个领域和他们自己的经验和体会。
So, in fact, when you delivered this presentation in the IAAS conference in Croatia, I think that many attendees were already very interested in what you were talking about, your practices as well as your experiences.
Joana 给我最强烈的印象就是他们在做这类手术当中，对病人的处理不是一刀切的。是根据病人的不同的情况来区别进行对待的，也就是说呢，虽然都要求的是日间手术，但日间手术从遴选病人做手术到术后的处理，都充分的体现了具体情况具体分析，不同的病情区别对待的这样的一个原则，这是一个非常好的原则。
Yeah, so what impressed me a lot about your presentation is that you didn't apply a one-size-fits-all approach for all the patients. In fact, you used a case-by-case approach to deal with the patient, in terms of patient selection, the surgery, as well as the post-surgery care. I think this is a real patient-centric approach, and that's why you have very good results.
包括术后的观测时间，以及他是否留院过夜观察，这些都充分的体现了他们从保证手术的质量和病人的安全出发所采取的系列措施。
Yeah, so you talk about the post-surgery observation. Sometimes patient need to stay overnight in the hospital. That really tell me that you prioritize quality and safety over speed.
我觉得这一经验对全球推广日间手术来讲是一个非常好的经验。
I think that's a very good experience for many other countries.
再次感谢 Joana 给我们带来的分享。
So once again, thank you, Joana, for your wonderful presentation.
And Joana, I just have one question. You say you are combining abdominal wall reconstruction along with bariatric surgery, which includes intestinal bypass. So what sort of an abdominal reconstruction do you use in these kind of patients? Do you use mesh, and what type of mesh?
So for ambulatory setting, we are not doing right now the synchronous surgery because almost of them are more complex. But we have two kinds of patients right now. So we have very high complex abdominal wall problems with very big hernias in very obese people. And in that kind of patients, we prefer to downgrade the BMI first with medications, injections, and bariatric surgery first, and only after decreasing the BMI, we performing the abdominal wall surgery. But nowadays we are seeing another kind of patient, that is patients with obesity, but in the first grade, like between 30, 35, with primary hernias, umbilical, epigastric, multiple epigastrics with diastasis. And in that kind of patients, although we can do the same sort of first bariatric surgery and only after decreasing the abdominal wall surgery, because in the abdominal wall surgery we prefer a lower BMI in order to avoid infections and recurrence later. We can think, and we have some cases of synchronous surgery. They perform the bariatric surgery first, and after that, in a minimal invasive way, in the preperitoneal space, like PTEP technique right now, we perform the correction of the hernia with a mesh. Of course, that the bariatric surgeons don't have any kind of problems. If they have some kind of technical issues, we abort the correction at the same times of the abdominal wall. About what kind of mesh, right now we are doing with a regular polypropylene medium weight macroporous mesh. But we have some other choice in the marketing, and some meshes that are absorbable long time, and in the first part, in the first month, they have a very strong resistance, because part of the problems with patients with very high BMI is the necessity of high resistance in this interval. So we have other choice others than the regular polypropylene.
Okay, thank you. No, I'm just interested because you said synchronously you're doing both the surgeries, and when you're doing a intestinal surgery,
Yes.
I think you don't put in the complex obese patients with complex hernias together.
No.
You don't use mesh when you're doing an intestinal surgery. That's what I infer.
Yeah.
In very complex cases, we are doing first the obesity surgery, and in the second surgery, month later, the abdominal wall surgery.
Okay. Thank you.
Thank you.
Makes sense. Makes sense. So, unfortunately, we don't have the third speaker. And so we will conclude the fourth webinar now. And I will thank both the moderators to take the time out and come for this webinar, and both the speakers. Thank you very much for being part of the web series. And I hope that we'll have more and more participants as we go along. And till next time, till we meet again, 15 days later, we will,
Bye-bye.
I will say bye to everyone. Thank you. Thank you so much.
Thank you.
Bye-bye.